And Dr. Hari is a professor of medicine in the division of hematological malignancies and adult bone marrow transplantation in Medical College of Wisconsin, and he's also the scientific director of the plasma cell disorders and adult solid tumors working committee of the CIBMTR. He's going to talk about integration of new agents with transplantation immunotherapy in multiple myeloma. Please.
Thank you, Professor Gorman. Thanks to all of you and Professor Bekshach for inviting us again. This is, as Chris said, we thoroughly enjoy Turkey. I feel like if I have a next birth, I'll be in Turkey. I'll be born in Turkey. So going from autoimmune to myeloma, so the most rare disease to the most common disease for transplant. So we'll talk a little bit about newer agents and how we integrate that into multiple myeloma management. And the main thing to note is that we have 7 new drugs approved in 2015. If you look at the indications for which they were approved, there are 16 new indications approved. Median patient survival has increased 3 or 4 times, and but still, almost everyone with myeloma dies of myeloma. So there's, the list of drugs are there, and it's amazing that many of them are represented in our symposium in the pharma section upstairs. So you have accessibility to many of these drugs. That's amazing. And again, we still have the original framework of how we treat newly diagnosed myeloma. So we have to divide them into transplant candidates and non-transplant candidates. And especially, the European approach is to limit transplant to the age of 65. In the US, we don't have an age limit. It's just your performance status and your comorbidities that determine who gets transplanted. And for the people who get transplanted, the common paradigm is to do a transplant. There are some people who still debate early versus delayed transplant, and then we can talk about that in a second. And then followed by maintenance, and some people call the more aggressive maintenance as a consolidation. Nobody really knows the difference between consolidation and maintenance. And then for people who are non-transplant candidates, it's induction treatment followed by extended long-term treatment. So if you look at the new combinations, the questions are, what are the new combinations, and what is the timing of transplant, early versus late? So if you look at the New England Journal of Medicine, in the last week we had the French IFM 2009 trial that was reported, and if you look at the conclusions in the abstract, they say this trial does not show any difference in overall survival between people who had an early transplant versus late transplant, and therefore, so it kind of gives the implication that a later transplant might be okay in terms of overall survival. In my opinion, that trial is, that conclusion is not warranted in that trial, because the trial was only powered to detect a progression-free survival, which was totally in favor of early transplant. So we can look at the modern studies of early versus late transplant. So there was the Italian study, which was transplant versus melphalan prednisone Revlimid after Revlimid induction. Similar sort of Revlimid induction followed by transplant versus cyclophosphamide dexamethasone Revlimid. And then the French study, which used more modern induction with bortezomib Revlimid dexamethasone. And then the EMN study, which used bortezomib, Cytoxan, dexamethasone, and then transplant versus a non-transplant arm. All of these were early versus late transplant. And one thing is clear, progression-free survival is significantly better for early transplant. So we should still be doing transplant, because these studies were supposed to detect a PFS advantage. They did detect a PFS advantage. And more than that, among the people who miss out on the early transplant, if you choose a delayed transplant, the best percentage that can actually get a later transplant after this is about 78%, and that was in the French study. In the other studies, it's about 2/3. So if you have an intention to do a late transplant, only about a third of the patients actually fail to get it. So these are the first 2 studies, and then this is the EMN study, which is the largest, and this study is still ongoing. So after Cybord induction, which is cyclophosphamide, bortezomib, dexamethasone, it's VMP, Velcade, melphalan prednisone in the control arm, and high-dose melphalan single or double transplant, followed by consolidation versus no consolidation, and maintenance for everybody. So there's 2 questions. early transplant versus late transplant, and the late transplant got VMP. And for the people who got either, you get consolidation versus no consolidation. And this study has not been published, but as you can see, in the study population, if you look at all comers, early transplant had a progression-free survival of that was not reached versus 42.5, and at 3 years, the difference is almost 8-9%. Hazard ratio is already significant for progression-free survival. So your chance of progressing is much higher if you miss out on a transplant up front, although you got a lot of Velcade, and you got consolidation in half the people, and you got Revlimid maintenance. So this group, actually, only thing they missed out was high-dose melphalan. They got low-dose melphalan. If you look at the high-risk patients, the progression-free survival difference is even more dramatic. So this is almost 23% more. And the high risk in this group, high risk who got transplant, are behaving like the standard risk who got VMP. So it kind of equalizes them to almost a standard risk. So, and again, so this again tells us one thing, that if you behave like a VMP group in PFS, doesn't mean that you're going to behave like that group in overall survival, because these patients are going to have a much shorter overall survival than even these people. So this is the IFM study that was just published in New England Journal about a week ago. So this is the progression-free survival of people who got RVD induction followed by transplant versus 2 cycles of consolidation in the transplant arm, and then RVD only 8 cycles here. So the difference is that these people got 5 cycles of RVD and a transplant, these people got 8 cycles of RVD. And this is the most accepted study with that question, because most of us in the US end up using RVD as our induction therapy. And in Canada, I think it's still dual agents, CyBorD or there is an MRD assessment, minimal residual disease assessment with flow and next-gen sequencing here, right after transplant or after the comparison arm, and an MRD assessment while on lenalidomide maintenance. This study gives us the answer to a lot of questions, not a conclusive answer, but a very interesting answers. So the progression-free survival is clearly in favor of transplant. There's no doubt about that, and like all the other studies that have shown that. Overall survival is very similar and hasn't shown a difference. This is the progression-free survival based on MRD status and actually this is MRD status and overall survival. So if you achieved an MRD negative condition by flow cytometry after transplant, you had a better overall survival even within the time period of detection. So this is within 4 years. So that difference is already obvious. If you look at MRD during maintenance, so this is the landmark analysis starting at 0 months, and this is why after, and you can see that in the French group, they only do maintenance for 1 year, unlike in the US where we do maintenance till progression. So the French give maintenance for about a year, and whether you're MRD negative or positive, for that first year you're doing okay. So even if you're MRD positive, your maintenance is actually helping those people. That's the first conclusion. The second conclusion, once the maintenance stops, both people actually start relapsing, the positives faster than the negatives. So it tells us both the excitement about an MRD, because the negative people are relapsing slower, but it's also the downside of MRD in that MRD doesn't equate to a cure, at least in myeloma it doesn't. So this is, again, very interesting data that shows that. There is one, if you look at the supplement of the paper that's in New England Journal, you'll find that they have stratified MRD negative and positive patients by with transplant or not. So there are 4 curves: MRD negative, transplanted; MRD positive, transplanted; MRD negative, no transplant; MRD positive, no transplant. And in that analysis, MRD negative and transplanted is better at progression-free survival, despite MRD overall not being the big differentiator. So it tells you that even if you're getting MRD negative, the way in which you get to MRD negativity, either through a transplant or without a transplant, makes a difference. So if you are presumably getting to a post-transplant MRD negativity, you're doing better. Now, this is actually even more interesting. So the question really is that, so the question we are trying to answer here is, as our induction treatment gets better and better, we have more and more people achieving, after 4 cycles, a deep remission. How are those people going to do if we skip transplant? That's the question that everyone is trying to answer. I don't know why we have to ask that question, because transplant in myeloma is very simple. The risk of mortality is about 1 in 1,000 at this point. because when we look at the CIBMTR databases, about 10 people die from an auto transplant for myeloma every year, out of about 7,000 people who get it done. But we still ask that question, and so far we haven't come to a point where that question has been in favor of the non-transplant arm. But still, as our induction gets, let's look at carfilzomib Rev-Dex induction. This is two sets of studies done at the University of Chicago and by the Multiple Myeloma Research Consortium, where they gave for carfilzomib Rev-Dex induction, then transplant, and then carfilzomib Rev-Dex consolidation, and then carfilzomib Rev-Dex maintenance. So it's a pretty intense protocol. It's almost like the Arkansas protocols, except that there is less chemo. And then at the same time, or before this, they actually did a non-transplant study where KRD induction and patients who were transplant eligible just got collected. They actually didn't go through the transplant. And then they got consolidation and then maintenance. So basically we have two side-by-side, almost side-by-side studies which looked at that question. And again, very detailed MRD analysis at 4 cycles, 8 cycles, 18 cycles. So this whole protocol takes about 2 years to run through, and then you're on maintenance. It's a very intense protocol. So if you look at the transplanted group, so the responses, this is by the different kinds of responses. At 4 cycles, 73% are in VGPR, very good partial response. 23% are in near CR, 16% are in CR, and 11% are in stringent CR. Once you do a transplant and followed by 4 more cycles, you immediately convert that to 91% VGPR, and stringent CR rates almost 63%. Once you continue with KRD, if you continue with KRD maintenance, you're getting almost 85% of patients into a stringent CR. It's very impressive. What about the non-transplant group? The best you can get with 18 cycles of KRD, that's you keep on doing it, it's about 50%. So about 30%, there's a 30 percentage point difference in the number of people who get to a complete remission. This study is not yet looking at the duration, so we don't know that, but it again tells you that there is some added benefit to a transplant, which is actually a cheaper method of doing this than any of these other treatments. So then the question becomes, so I think we have conclusively answered that at this point transplant is still safe, cheap, and one of the best ways of getting the majority of patients into a deep remission. Next question is, what do you do after transplant? So the standard of care right now in the United States is lenalidomide maintenance, and I think that should be the standard of care worldwide. There have been 3 studies, and this is a meta-analysis of those 3 studies. This is CLGB 100-104, IFM 2005-2002, and the GIMEMA study, one arm of which received maintenance. So the treatments were placebo versus len, and no treatment. And one of the studies had a len consolidation. So if you look at their data again, these data are very powerful. This is almost 1,000 patients, 1,200 patients divided into these 2 groups. There's a 12% point difference at about 7 years in terms of overall survival. And any group you look at, all of these are trending towards a benefit for lenalidomide. So the conclusion is that len maintenance after transplant reduces the risk of progression or death by 50% in newly diagnosed myeloma patients. And it significantly prolongs overall survival in this meta-analysis. This meta-analysis actually weighted more towards the CLGB study, which is the only one that actually showed overall survival difference in the study itself. We have actually updated that data, and it's coming out soon. And the FDA actually did an analysis now, and the FDA found that in the CLGB study, for people getting whatever induction, so in the CLGB study, people got Rev-Dex, Cyborg, VRD, many different kinds of inductions. In fact, there were a couple of people who got VAD induction too. The median overall survival was 111 months, which is almost 10 years. So this is in 2004. 50% of those people who got a single transplant followed by len maintenance were alive almost 10 years later. So this is actually the best data that we have for overall survival in myeloma in any group. So I think and even in the French study, the overall survival was about 106 months. So these are the data that came out from the FDA. So you can see in the US study, 9.3 years, almost 10 years of median survival, 7 years for the people who got placebo, and in the French study, 8.8 years versus 7 years for the placebo group. So this is the benefit of, and again tells us that you need to wait for a long number of years before you see an overall survival difference too. So in the US, our group, the BMT-CTN, which stands for Bone Marrow Transplant Clinical Trials Network, we did a study called the Stamina Study, which looked at the question. So I just showed that transplant is needed, lenalidomide maintenance is needed. So can you do better than that? Can you do more than len maintenance with something more intense? So one thing you could do is a second auto transplant and then len maintenance. The other thing you could do is to do consolidation with RVD, just like some of those things we saw. So this was a large randomized study looking at those three arms. So control arm is len maintenance alone. One arm is consolidation followed by len maintenance. The other arm is a second transplant followed by len maintenance. So fortunately and unfortunately, there is no difference between any of these. So it tells us that right now, with our agents that we have, the best thing you can do is just len maintenance. There is no additional advantage to piling on more treatment after an auto transplant. Do an auto transplant, len maintenance. And the standard of care in the US, based on this study, is to continue it till progression. And the median overall survival in this study is set about 80 months for our maintenance. Again, this is a curve. These are the curves of the study. Essentially no difference. Overall survival, no difference. There is a study from Europe which kind of goes against it, which is the EMN study that we just talked about earlier in the context of early versus late transplant. In the EMN study, there is a consolidation arm after the transplant or the non-transplant group. But the big difference is that the EMN study specified what induction you have to use, cyborg induction. So they actually did not use VRD as induction, whereas in the US, we actually used a lot more VRD. And if you look at the patients who got, these are the people who got VRD consolidation, the EMN study, and they're actually showing a PFS difference for people who got a VRD consolidation. So if you look at this their study, the only time they get the combination of proteasome inhibitor and lenalidomide is after transplant as consolidation. Whereas in the US, the majority of our patients are getting it up here. So that may be why we can't show a difference for VRD consolidation post-transplant. So this is the US data. So 60% of our patients are getting VRD upfront, and very small percentage of our patients are getting cyborg. Next question that again that keeps on getting asked is, do older patients derive similar benefit from transplant? This is a large CIB-MTR analysis that we did. So whether you are 70 years old, more than 70 years of age, 60 to 69 or less than 60, your progression-free survival is exactly the same after an auto transplant. So in terms of myeloma benefit, older patients derive very similar benefit from transplant as younger patients. Second question, renal impairment. Again, this is another common question that we get asked all the time. Whether you have renal impairment or not, your overall survival and progression-free survival are very similar nowadays. This is because we have very good agents that work in patients who have renal impairment. Previously, when our agents were limited to chemotherapy, renal failure was one of the biggest prognostic factors for myeloma. Because if you're on dialysis, you could not have full doses of many of the chemotherapy drugs. Now, even if you're on dialysis, you're eligible to get full doses of bortezomib, full doses of carfilzomib, full doses of daratumumab, and many other agents. So that's why auto transplant benefit is no longer limited by renal failure. Next question, salvage transplant at relapse, and many of you are familiar with these data. That is the only randomized study of salvage transplant at relapse. So to do a salvage transplant at relapse, you need to have done the first transplant up front. So that's another corollary. If you should have collected the cells up front and done one transplant, and then when the second transplant, when they relapse a bit later, you could think about a second transplant. It was limited to people who had at least 18 months after a prior auto transplant. And everyone got induction with bortezomib, adriamycin, dexamethasone, and they're randomized to melphalan and transplant versus cytoxin maintenance. So this study again showed an overall survival difference. It was published in Lancet, and we again did this study in the CIB-MTR and showed that salvage auto has actually a median progression-free survival of almost 3 years. So this is the myeloma 11 study from the UK. And many of you are familiar with this. This again, is a large study that is not yet complete. At this time, they have a maintenance of lenalidomide data that have come out. Again, here shows that with lenalidomide maintenance versus observation, they have a significant progression-free survival difference. More importantly, in this study, it shows that the benefit of lenalidomide maintenance accrues mostly to people who are standard risk. So they again raise the question, for high-risk patients defined by cytogenetics, should we do some other strategy? And again, that has not been answered, but there are some people who use a 3-drug maintenance regimen, such as VRD, after auto transplant for people with high-risk disease, such as, say, people with plasma cell leukemia or people who have 17p deletion, etc. We don't have randomized data showing that it's beneficial, but it is clear that high-risk patients should definitely get a transplant and should go on some form of maintenance afterwards. So again, another common question that comes up is, should you do 3-drug induction or 2-drug induction? I think many countries don't pay for 3-drug induction because it's more expensive to pay for bortezomib Revdex. Here is the data that just got published by Dr. Dury, this is a randomized study of VRD versus RD, and actually that showed an overall survival difference, but notably this study was not direct. These patients, majority of them actually did not get a transplant. But irrespective of whether you get a transplant or not, your overall survival is better if you start out with VRD. After a year, everyone was on RD maintenance. Here is the progression-free survival in that study. And again, I know that many countries use 3-drug induction with VCD, which is Cyborg. And here is a study from the IFM group again of 4 cycles of VTD, which is bortezomib, thalidomide, dexamethasone. So that's a proteasome inhibitor, thalidomide or IMiD combination versus an alkylator IMiD combination. And they clearly showed that you have better VGPR rate and better CR rates, but more importantly, VGPR rates at 4 cycles. You're already ahead of the game a little bit at 4 cycles if you do the proteasome inhibitor IMiD combination. And there are other biological reasons why that is the proper combination. But again, this is something that in the myeloma world we talk about a lot, because the term multiple myeloma, originally the people who coined that term used multiple myeloma to mean they have multiple plasmacytomas in the body. However, now we know that it's not one disease. By the time patients come to light, they have multiple different clones. Some of these clones are competing with each other, and sometimes only one clone is dominant. And when we do an auto transplant, it creates a bottleneck for the clones, and sometimes you get an escape with a different clone, and those people relapse early. Sometimes you get an escape with the same clone later on happening. Those people that tend to do better. And there is a competition for the bone marrow niche that's artificially induced when you do a rapid debulking treatment. And again, auto transplant is lymphodepleting. So if there was an immune system that was keeping some of the clones in check, you might actually make things worse by taking away that immune system. Just as Dr. Bredeson's patient's immune system was taken off and their autoimmune disease got better. So we are now focusing more and more on immune-based therapies after transplant. And what that can do is get people back into a stage of MGUS or smoldering myeloma where there is a stasis or a punctuated equilibrium where the immune system keeps those clones in balance. And all of you have had patients who did not actually get into a complete remission after an auto transplant, but they were in a PR, and they've been in a PR for 5 years, 10 years, 8, I have people who are 15 years out, still in a PR. So the benefits of, that's why we have these debates at myeloma symposia where people debate should, complete remission better or not, MRD better or not. Yeah, so obviously a better response predicts a better survival in every disease that we treat. But there are people who don't need to get into a complete remission, but can still do well, and those are patients who are actually have a stasis situation from the myeloma. So quickly, I'll talk about that and then wind up. So we have a variety of strategies that that many of us are doing. So one is vaccines. There are multiple different kinds of vaccines that are in trials right now. The one that I am most familiar with is a dendritic cell myeloma cell fusion vaccine, which we are creating in combination with Dr. David Avigan's group from Harvard. And these are some of the vaccines that are in development right now. And the whole point is to reduce the immune suppressive environment that we create artificially after transplant, but in other words, to augment myeloma-specific immunity post-auto transplantation. And that we think is the best time to do any strategy like that, because you are in a relatively lymphodepleted state, and there is homeostatic proliferation of lymphocytes, which we can manipulate to our advantage in that setting. So we can go straightly. So, sorry, I'm quickly going to that. So one of the groups which we need to specifically target are the people who relapse early after an auto transplant. Here is data from the CIBMTR. If you relapse within 2 years after an auto transplant, your 5-year overall survival is 32%. If you don't relapse in 2 years and do a landmark at that point, 80% of those patients are out at 5 years. In fact, this turns out to be a better prognostic marker for myeloma survival than any of these other markers. So it's kind of like when the New York Marathon starts, you don't know who's going to finish. This guy looks like he's going to finish faster, and this guy looks like he's going to finish last. But at mile 15, if this guy's already dropped off, this guy won't be winning. So that's kind of like that. So, and if you look at how many patients relapse early within 2 years, this is the IFM study. It's the most recent study that we have, okay? Good induction, good maintenance. 10% of MRD negative patients have already relapsed at 24 months. And 30% of MRD positive patients have relapsed at 24 months. So we still have a long way to go for those patients. So those are the patients that we are targeting in more aggressive approaches such as allotransplantation. So we know that from Dr. Garton's original paper in 1991 that allotransplant can cure some of these patients. But there is definitely, and rightly so, reduced interest in allotransplant because we can give 50% of people 10 years from myeloma start without an allotransplant, with a single auto transplant and then maintenance. So we should not be giving allotransplant to everyone, clearly. So, and you all know why allotransplant works, and because of these data, the question becomes who can benefit from an allotransplant now? Who are the people who we should go with this allotransplant approach? So high risk subset, and then some of these patients for whom an allo immune system is better, and for those patients, should we use allo immune system as a platform for immune modulation? So there are some data that for specific high-risk patients, such as with those with deletion 13q and 17p, allo does better than auto. And these data have not been published, but these data are coming soon. This is the BMT-CTN 0102 study where we compared allo versus auto versus auto-allo, so tandem auto versus auto followed by allo. Again, in these data for our high-risk patients, which is only a small number of patients, 37 patients, we actually couldn't show a big difference but in PFS or OS. But there was a difference in the number of people who relapsed. So as you can see, auto-allo patients were much less likely to relapse. And once you relapse, it turns out quite clearly that patients who relapse after an allo tend to do better than patients who relapse after an auto. This was shown by two groups. One is this is the CIBMTR data that we presented at ASH and is under review for publication right now. Here are people who relapsed after an auto versus allo. After about the first 18 months, auto-allo patients are doing much better. So if you have an allo immune system, it synergizes with our current myeloma treatment much better. These and identical results were shown by the EBMT group in their randomized study. So we have two sets of provocative data showing that allo immune system is better at relapse. So that, being said, the patients who I think should be targeted for allotransplant are the people with the highest of the high risk. So, people with plasma cell leukemia again, people with RISS stage 3, people with 17p deletion, etc. And the competition to allotransplant is CAR T cells. And the most attractive CAR T cell target right now that we know of is BCMA or B cell maturation antigen. There are at least 3 groups working on this right now. There is a company called Bluebird Bio, which has got a technology by which their CAR T cell BCMA CAR T cells, at least from somebody watching it externally, doesn't look like it is too toxic, and has shown anti-BCMA activity. This is the study from the NIH that used that technology. And there are many other targets, CD19, CD138, kappa light chain, CS1, CAR T cells can be generated. However, the problem with CAR T cells, again, this is a CD19 CAR T cell to a patient who had an auto transplant followed by CD19. So this patient had multiply relapsed. So you can see they had an initial auto transplant, len maintenance, len-bortezomib, dexamethasone, multiple of high-dose cytoxins, finally got MEL-140 and a CAR T cell with CD19, and the patient went into remission for a long time. They published with this single case report, but the problem is that CD19 is undetectable on the plasma cells, and you actually don't know what it's working against. But clearly the patient did well. Early data for the BCMA CAR T cells show that many patients can get into deep remissions, but the duration of remissions at this point is low. But out of 11 patients screened, only 6 could be treated, because they're only treating patients who have BCMA expression, which is not everyone with myeloma. And they have major complications like PRES and CRS, which are probably we are less equipped at handling than allotransplant complications. Finally, this is something that I'm very excited about. Haploidentical transplants with post-transplant cytoxin for very advanced myeloma. So these are people who have multiply relapsed, you have really nothing else to offer, or you have 1 or 2 things to offer. So again, this is data on all the haplos that have been performed in America till now. So about 41 transplants, including 17% with plasma cell leukemia, 41% of patients with HCTCI scores or SOROR scores of 3+, and the majority of patients were very, very advanced, more than a year out or 2 years out from diagnosis. TRM is very low. That's the attraction for this approach. So these patients have a treatment-related mortality of 8% at 2 years. And you can see that the PFS is almost everyone relapses very quickly. By about a year, everyone has relapsed. So, but remember, these patients have failed almost everything known to mankind at this point, and they're relapsing. And it's not too bad that they're relapsing, because my argument is that we have much better agents to use. Here is our own approach at our institution, where we do haplotransplants followed by prophylactic donor NK cell infusion. So I'll leave you with a patient that we treated on this approach. So this is somebody who had 414, 1114, 1Q, trisomy 16, abnormal 6P, and abnormal 12 and 18 at diagnosis. So this patient has fairly advanced myeloma at diagnosis. So he gets treatment with upfront VTD times 4 cycles and an auto transplant, and then I put him on bortezomib maintenance. This was in 2008, because the patient has 414 and translocation. He relapsed in 2009, about 13 months after auto transplant. And at that time, I treated him with cyclophosphamide, bortezomib, Revlimid, dexamethasone for 6 cycles, and he got into VGPR, and he needed X-ray radiation treatment for spinal cord compression. So then he remained on VRD maintenance, and he relapsed again about 18 months after that attempt. At that time, we gave him VD pace times 2 cycles, and he achieved a PR, but he went to transplant with a marrow of 20% plasma cells with all those abnormalities. So this patient, at that time, we don't have access to carfilzomib, we don't have access to daratumumab, we don't have access to pomalidomide. He has seen every agent in myeloma by this time. So we did a haplo transplant with NK cell DLI afterwards on day 7, and he is still alive in remission with MRD negativity now. So this is 2012, so it's 5 years plus. The transplant was in March or April of 2012. So it can be done, but haplo transplant is associated with low TRM, but we need to do something beyond that. There are many approaches that can be done. One of the things that we are discussing with companies is to think about integrating PD-1 antibodies in that setting, so that we augment that immune system. Another approach might be to do NK cells. Another approach may be to do plant DLIs with T cells. But I think an allo-immune system is very beneficial to many patients with myeloma, and that we should not be doing it in every patient up front, but we should be using it in patients like this who have nothing else to do, who we have nothing else to do. With that, I'll take some questions.
Okay, sure. Thank you for your excellent presentation. Yes, please.
So you finally convinced me about maintenance, but you didn't talk about any of the serious potential late effects.
Of maintenance.
Cancer, prolonged maintenance. Did you talk about, we know more about that?
Yeah, so clearly lenalidomide maintenance associated with this increased risk of second cancers. So myeloma by itself has a 1 to 2% risk of second cancers without even using high-dose melphalan. The people who get highest risk of second cancers with lenalidomide are the people who get high-dose melphalan. Actually, the people who get low-dose melphalan with Revlimid have the highest risk. High-dose melphalan is the second highest risk. And those patients, the risk is thought to be about 6 to 7% at this point, 5 years. The two biggest second cancers are myeloid malignancies and lymphoma or lymphoproliferative malignancies. AML, MDS, ALL, we have seen everything with that. Also, there is a risk of solid tumors, which is about 3%. Overall risk of second cancer is about 7%. The majority of those events seem to happen in the first 2 years. After that, it seems to taper off. But again, there is an ongoing risk that keeps on going. We did a large analysis again from the CIB-MTR, which is a better way to do this analysis than going to trials because there's a lot more patients. Turns out that age more than 70 and male sex are the only two risk factors which we could identify, but which is age over 70 and but again, those are the people who are at risk of getting cancer, right? So it's and male sex, and males are more likely to get it than females in our analysis, but nothing else shook out. But that is a risk for long-term maintenance. But again, the results are very clear that maintenance is pretty strongly associated with survival.
Any questions? Yes, please.
What is the conditioning regimen for haplo transplant? This case had 2 autologous transplants already.
So we do one autologous flu-cy TBI. We didn't give any. Nowadays, we use Flumel for the haplo transplants. Flumel. But in this particular case, we actually used flu-cy TBI, the classic regimen.
And you give cyclophosphamide?
Yeah, low-dose cyclophosphamide. Flu-cy TBI with 14.5 of cyclophosphamide. Before and post size 50, yes.
50.
Yeah.
So just a really basic thing, you talked about being able to get patients through autos with renal dysfunction. When do you